Hi, I'm Dr. Anna Konstantinidis, and today I'd like to talk about a case that I call uncovering vision of the covered eye. So let's talk a bit about our patient. We had a 77-year-old black French male present to clinic. He had a long-standing history of reduced vision, left eye more so than right, growths over both of the eyes, and he had originally been referred for surgical excision. His previous ocular history includes a prior diagnosis of pterygium of both the eyes, chronic dry eye, he's had recurrent scleritis, peripheral ulcerative keratitis, he's pseudophakic in both eyes, and he has had an amniotic graft of the right eye. His medical history includes a diagnosis of rheumatoid arthritis, high cholesterol, high blood pressure, and this patient is in remission from prostate cancer since 2015. Medications he is currently taking include methotrexate, folic acid, simvastatin, amlodipine, allopurinol, and he is using cyclosporin 1% to manage his dry eye. So what did we find during the exam? We did see reduced vision of both of the eyes. Right eye 20/50 can pinhole to 20/40-2, left eye 20/100 and could pinhole to 20/50-. Due to growths over both of the eyes, there were hazy views of the pupil, but we could appreciate they were equal, round, reactive to light, and there was no APD present. His pressures were within normal range. Otherwise, slit lamp exams showed significant findings of meibomian gland dysfunction, ptosis of both of the eyes. He did have scleral thinning almost 360 in both eyes. We could see peripheral scarring and corneal neovascularization. However, we could not appreciate any elevated growths. It was an intact epithelium. There were not any cells or flare in the anterior chamber and no significant staining. Doing a dilated exam, we saw there was no remarkable findings in the back of the eye. So what do? We sent him for an anterior segment OCT. We took some photos at the slit lamp that showed us the neovascularized growths obscuring the visual axis of both eyes. And just to confirm there was no other hiding autoimmune condition that was contributing to the eyes, we sent for Sjogren's testing, which came back negative. So some of the differentials we're considering at this time is a pseudopterygium, limbal stem cell deficiency, pterygium, atopic keratoconjunctivitis, ocular surface squamous neoplasia. So here are pictures of the anterior segment OCT from the patient himself. And we can use this tool to aid in our diagnosis because what it did for us is it revealed corneal thinning beneath the conjunctival adhesions, which we couldn't see on slit lamp exam. So, what is it? Pseudopterygia are frequently misdiagnosed as pterygia because of their similar slit lamp findings, a conjunctival growth crossing the limbus. Unlike true pterygium, however, a pseudopterygium is a non-progressive conjunctival adhesion to corneal epithelium that often overlies focal corneal thinning. It arises when limbal barrier function and epithelial homeostasis are compromised. Pterygia often develop nasally, but pseudopterygia may develop in any meridian. Etiologies of pseudopterygia include ocular trauma or surgery, degenerative corneal disease, chemical burns, chronic inflammation, and even peripheral ulcerative keratitis, according to the literature, is an etiology of a pseudopterygium. In this patient, long-standing rheumatoid arthritis with recurrent scleritis and PUK produced chronic surface inflammation that promoted the pseudopterygium formation in both of his eyes. So, what did we do? Because pseudopterygia are rarely reported and often mistaken for pterygia, it is important to reach the correct diagnosis, as was done with this patient. By doing so, you can rule out surgery as it is not first-line treatment for pseudopterygia. This patient's chronic inflammatory background from rheumatoid arthritis, which did involve recurrent scleritis and peripheral ulcerative keratitis, created a chronic inflammatory status on the front of his eyes. So we adopted a vision-restoring and surface-supporting approach by fitting a PROS lens device to assess visual potential and restore epithelial homeostasis. Here are pictures of the patient's eyes when we fit them in the PROS devices. The PROS lens vaulted the adhesion, protects the ocular surface, and produced a substantial gain in visual function, with vision improving to 20/20 right eye and 20/30-2 of the left eye. Because pseudopterygium is non-progressive and reoccurrence risk is heightened in inflammatory disease, long-term PROS wear offers a reasonable, less invasive alternative to surgery while preserving future surgical options. This case highlights that corneal scleral growths are not always pterygia, and in patients with ocular or systemic comorbidities, alternate diagnoses should be considered. Testing such as anterior segment OCT can aid diagnosis by revealing corneal thinning beneath conjunctival adhesions, which is not evident on slit lamp exam. This novel approach to PROS for pseudopterygium demonstrates the value of a non-surgical option that protects the ocular surface and improves vision, therefore avoiding surgical risk and minimizing inflammation. Thank you for your time, and I hope you learned as much as I did.